Okay, thank you. Thank you. Yeah, so thank you so much, and thank you for the opportunity to present to your session. And I actually went into the website to look at presenters, and I saw some very impressive presentations, and I hope mine will be just okay, so you may enjoy as well. What I'm really presenting is the sort of a research idea that I've been developing for some time, and been adding different bits to it to kind of move towards establishing trauma-informed addiction care. So I gained some interest in post-traumatic stress disorder in people who use substance. And so the idea is around people on methadone services, trying to establish the burden of post-traumatic stress disorder, but also try to validate a screening tool, and hopefully introduce seeking safety therapy as one of the tools in opioid users in MAT services in Tanzania. So, so this is something most of us know. The number of people who use illicit drug it's quite huge, around 275 million. This was the one from 2016, and 53 millions used opioids. That was in the same year. And also we know that the rate of adverse experiences in people who use drugs is quite high, and it also sort of manifests in terms of post-traumatic stress disorder. And some studies have shown the prevalence to be as high as more than 40% who use drugs. And obviously, if you have PTSD as a drug user, it would have a negative impact on your adherence to treatment, but also overall on your recovery. So if we are able to address trauma when we are treating people with addiction, we expect to get better outcomes in terms of psychiatric comorbidities such as anxiety and depression, but also we expect people to have better adherence to treatment and also improve their quality of life. So this is sort of something that is known. Just a little, this may be a bit unnecessary, but I think we all know what is PTSD. It's a common mental disorder, usually triggered by having a terrifying or life-threatening event. And then you get these symptoms, and these are the sort of the four classes. You re-experience, but also you get some avoidance by avoiding the places which sort of remind you of the event. But also you can get some negative cognitions. You can have some self-blame, but also you can have sort of loss of interest, the typical negative mood symptoms. And then you can also have other symptoms such as sleep disturbances and so forth. So there are several factors we have associated with post-traumatic stress disorder. The type of trauma is quite important, and it has been shown that interpersonal violence is a very high risk of developing post-traumatic stress disorder among the different types of traumas. But having a younger age, being a female also is also more riskier than being a male. Being unmarried is also one of the risk factors. The less education you have, the more likely that you can get PTSD, and so social status, having a lower household income, and also being unemployed are some of the factors that would be associated, which are associated with PTSD. So this is the sort of a description of the the PCL5. The PCL5 is a tool which is widely used for screening PTSD. It has questions. It has a Likert scale, and then you have those 5 points from 0 to 4, and the total score could be 0 or could be 80. And usually a cutoff score between 31 and 33, you would say sort of, you can say you have a provisional diagnosis of PTSD. So the tool was actually validated in Zimbabwe in an outpatient clinic, and the cutoff point of 33 was found to have sort of the optimum psychometrics, 5 and specificity of 70.6 and internal consistency of 0.92 of the Cronbach alpha. So really, and the typical PCL5 is usually administered by the client. It's sort of it's a self-administered tool, but the one they used in Shona were administered by specific interviewers. And this is something that I kind of picked up from. I think one of the reasons they did that is because the ability of the clients to read and understand the questions from the tool was kind of questionable. So they thought it would be easier to have people to kind of interview them. So this is Seeking Safety. Seeking Safety is a treatment manual for PTSD. Sort of, it's a manualized therapy. It could be offered as individual or group therapy, and it was actually developed by Lisa Najavitz, who actually works at Boston University. So it has 25 topics, and they're all focusing on safe coping skills, and it can be delivered between 60 minutes to 90 minutes, and it has been shown by different studies to be very effective in treating co-occurring substance use disorder and post-traumatic stress disorder, but also has been shown to be effective in reducing behaviors among drug users as well. And the good thing about Seeking Safety is that it can be delivered by someone who doesn't have very advanced mental health training. You don't need to have a degree in psychiatry or a master's in psychology. Anyone who can be trained, even if you have sort of minimum education, and this makes it sort of ideal for a setting such as ourselves, where we don't have people who have advanced mental health training. So in Tanzania now, we know the burden of substance use disorder is quite high, and there's an estimate of people who use drugs around 300,000. And here we are talking about the illicit drugs, and about 30,000 of them are people who actually inject drugs. And the rate of interpersonal violence, there was a study which was done in Tanzania among people, women who use the substance, was found to be as high as 80%. So 80% of women in that population actually had interpersonal violence. But when it comes to post-traumatic stress disorder, we don't have any data in the community or even within our addiction clinics. So in 2011, we started having these methadone clinics as a response to the growing drug use problem, which was associated with high rates of HIV infection. Actually, by the time the prevalence of HIV in the country was about 5 to 6%, and the one in the drug using population was more than 40%. So it was really, really serious. So the clinics are located in 9 regions in the country, we have about 26 regions, so very few compared to the demand. And they offer integrated care, including HIV testing, counseling and treatment. We also focus on hepatitis screening and also treatment. And we offer treatment for other physical conditions, but also for mental conditions that may be associated with the drug use. But we face lots of challenges in terms of adherence to treatment, but also the recovery rates are quite low. So we, as I said, so we don't have any screening tool as part of the sort of the routine functioning of these methadone clinics. And we don't have any sort of standard post-traumatic stress disorder or sort of SUD co-occurring kind of treatment. We do see some cases of PTSD in this clinic, and people sort of use different kind of approaches to treat them. And they usually the very sporadic that someone finds someone with PTSD because we don't actively screen for them. So the aim sort of the study or the research that I'm talking about really is to validate the PCL5 into the Swahili language and then kind of identify it as a screening tool, sort of a standard screening tool for PTSD among people who are taking methadone for opioid use disorder. But then also the other aim is to kind of estimate the PTSD burden and also associated factors among these clients. And the next phase, the idea is to kind of test the effectiveness of seeking safety intervention for PTSD and SUD co-occurring disorder. So the idea is potentially we can sort of scale it up to other clinics and then nationwide, and then sort of move towards establishing trauma-informed addiction care. Just so you can get a picture. So I work at Mirembe National Mental Health Hospital, which has different branches. So we have the main hospital branch, which is kind of responsible for the general sort of psychiatric care, adult, child and adolescent, but also lots of people with sort of neurocognitive issues, including dementia. Epilepsy is pretty high in our setting. And then we also have sort of integrated physical care. We have sort of a general medical clinic. We also have an ophthalmology kind of clinic. We are trying as much to integrate the care. In one way, we are trying to reduce being the sort of specific mental hospital. And then the other branches of the hospitals are the forensic side, which is sort of located in like maybe a kilometer away from the main hospital. And then we have this yellow building here, which is actually the addiction part of the hospital. It was established in 2018, and so it is one of the 9 methadone-assisted sort of the therapy clinics, but it offers more than methadone. So we have 2 wings. One wing is for methadone, and the other one is for people who are not having opioid use issue, people with alcohol use disorder, but also people with cannabis, which is also quite high in our setting. By the time I was preparing this slide, I think now we have a bit more than 500 enrolled clients who have opioid use disorder, and they come to the clinic daily for the methadone dose. But also they get as I said before, we are an integrated clinic, so they also get some other services apart from the methadone that they get. So, so my objective for the pre-intervention phase of the study is to do the PCL5 validation. So the idea is to translate and pilot test and then adapt PCL5 into the Swahili language, and determine the cutoff score of the Swahili version of the PCL5, which has the sort of optimum sensitivity and specificity, and then determine the internal consistency of the Swahili version of the PCL5. Then using the psychometrics from the validation study, then I would kind of work on establishing the prevalence of PTSD overall, look at associated factors, which could be demographic, clinical factors, or the trauma exposure, and possibly other factors as well. So the first phase for the validation, that would be a cross-sectional study. So actually, I was able to calculate the minimum sample size at around 163 individuals, and the prevalence study, again, cross-sectional, with an estimated sample size of around 372 individuals. These are the tools for the validation part of the study. So the life event checklist, it's sort of exposure to specific traumatic events, about 16 of them, including sexual, physical, emotional, and even some war and other kind of specific traumatic experience. And then, so this would be used in conjunction with the PCL5 to kind of screen for PTSD. And then later on, the CAPS-5, which is administered by the clinician, would be the sort of the gold standard for PTSD diagnosis. It has some pretty good psychometrics. So basically, the steps would be a client will be screened with the life event checklist and the PCL5. It takes about 10 minutes to do this, and we expect to use either a nurse or a medical doctor or a social worker, and then sort of a connecting a member of the team would take the results, and then connect the individual, the clients, to a psychiatrist or clinical psychologist who would administer the CAPS-5, which takes about 50 to 60 minutes for administration. And then later on, we would sort of compare the rate of agreement between the PCL5 and the CAPS-5 and figure out the specific psychometrics. And the other part would be to look at the associated factors. And then we have the socio-demographic factors: age, sex, education level, occupation, marital status. And the clinical factors would be the duration of substance use before the initiation of methadone treatment, but also the duration of methadone use, the dose the patient or the client is currently using, whether the patient had missed doses of methadone. And we have some ways to get this data from the pharmacy department. They keep track of everyone who takes the methadone doses on a daily basis. We can also check the concurrent drug use, and we use the urine drug screening for that. Cigarette smoking status, and the good thing about cigarette smoking is not highly, but it's acceptable in our culture. So this is something that you can establish very easily by asking the client whether they smoke, how much they smoke. They would respond very, very easily. comorbidities such as physical illness, but also mental illness. This is something we can get from the client's files. And then any medication which is being used by the client is also something that can be found in the files. So for the intervention phase, we expect to look at the effectiveness and acceptability of the seeking safety therapy. So effectiveness when in terms of reduction of the PTSD symptoms, but also reducing the concurrent drug use, and also change in sexual risk behavior. And the acceptability would be among the therapists who are kind of delivering the therapy, but also the clients receiving the intervention. So the idea is to do sort of a randomized control trial with sort of a waitlist control. So we would randomize the clients into two groups. One group will get the seeking safety intervention, and the other group will be put on a wait list. So in the case that we see that seeking safety is effective, we would start giving them the therapy afterwards. So at the baseline level, we would have to use the CAPS-5 to confirm the diagnosis of PTSD, and then we can get the baseline PCL-5 PTSD symptom score. And then we can get some information about their drug use and the risk behaviors. And then we expect at week 8, we can do the assessment again to look at the impact of the intervention when it comes to the PCL-5 score, the drug use, and also the risk behavior. The people who underwent the seeking safety therapy will have to be interviewed to determine the acceptability and other aspects of the intervention. So just brief on the data analysis. So the idea is to do the ROC analysis in the area under curve for the validation part using SPSS, and the prevalence and safety factors, typical descriptive, bivariate, and multivariable regression. And the seeking safety effectiveness and acceptability. For the effectiveness, we do sort of the intent to treat analysis and the t-test to measure the difference in the outcomes, and we'll do thematic analysis for the qualitative part, which would be the acceptability of the intervention. So really, if this kind of study is successful, the idea is then we can sort of scale it up at the national level, and then we would have to count it as one of the key elements of the MAT clinics in Tanzania. So at that point, we will have a validated screening tool, but also if the seeking safety is effective, then we can have a standard kind of treatment for people with PTSD, SUD, comorbidity. That would be the seeking safety therapy. So this is the PCL-5, just so you can see it. It's a very simple tool. Yeah. Yeah. I think. Thank you for that. Thank you for listening.